welcome Philip to UW. And he was the department's Bonica Scholars Research Program and obtained his medical degree from UCSF. We are really excited to have you and to learn more about your work. Over to you.
As you mentioned, I'm going to talk about perioperative risk prediction and then also some work that I've been doing to use language models to do that. Yeah, you mentioned I'm an anesthesiologist, and I did my clinical training at University of Washington. And a lot of the work that I'm going to present today actually is work that I did at UW and utilizes UW medicine data. And I also really encourage researchers to utilize the cloud compute grants. I was fortunate to have been awarded some of those cloud compute resources, and that's how I was able to carry out some of this research that I've done. So today I'm going to first cover what I mean by perioperative risk stratification, because this is very much a clinical thing that we do, and it's very specific to surgeries and procedures. And I'll talk about existing methods used clinically and some of the shortcomings. Then I'll talk about some of the work I did using a model called bioclinical BERT to predict a patient's illness severity in order to try and risk stratify a population of patients. And then I will talk about some of the explorations we've used. We've used large language models to do perioperative risk prediction. So starting off with what is perioperative risk prediction? I want to start off with just a patient vignette. So consider this might be a patient that will show up in the hospital. It's a 67-year-old construction worker. He had a shoulder injury, a rotator cuff tear, and it's affecting his ability to work. When you have rotator cuff tears, you can't move your arm very well. You can't lift things. His medical history is he has smoked for 20 years in the past. He has 20 drinks a week. He has high blood pressure. He has adult onset asthma that started about 15 years ago, but he didn't have it as a kid. On his father's side, there's been several family members with heart attack and stroke starting at ages 50 and 60, which is rather young these days. And occasionally he says that he may get some sense of chest pressure and shortness of breath, and but only when he has strenuous exercise or he's lifting a lot of weights. He doesn't regularly see a doctor, so we don't really know why. But currently he feels fine. So can we just take this patient to go to surgery? So this question comes up about 6 million times a year in the US, because we do about 6 million surgeries or procedures in the US across all our hospitals. And once a surgeon and proceduralist determines, yes, we need to do a procedure, then we need to ask the question, is it safe to do this procedure on this patient? Will the patient be able to undergo the stresses of anesthesia and surgery? Does the patient need any sort of medical optimization before surgery? And in some situations, is the patient too sick to even withstand the surgery? And is the surgery more likely to cause harm than benefit? So this fundamental question, is it safe, is difficult. It requires us to predict the future. There's no single ground truth definition or label for safe within medicine. And historically, doctors are really bad at predicting the future. But because surgery is a high risk, high reward event, the general expectation is that we do the best we can, and we try to do the best assessment and risk prediction we can. Just to give you an idea, at Stanford, we have a specific clinic that is dedicated to doing this. So after someone's been scheduled for a procedure or surgery, they are then sent to one of the anesthesia preoperative evaluation clinics. There's 6 of them across the San Francisco Bay Area. And staffing these clinics, about 25 clinicians every single day. They collectively see about 200 patients a day, which amounts to about 40,000 patients a year. And this doesn't account for actually all the surgeries and procedures. This is only the elective surgeries, the procedures that are scheduled in advance. We also have a hospital where there are inpatients, and sometimes there's a need for surgery or procedures that need to be scheduled same day or next day. And so they don't actually go through this process. But as an anesthesiologist or a surgeon, you still need to go through this exercise and kind of understand what the patient's risk profile is. At UW Medicine, there's a similar setup, and there's probably a similar volume of patients if you add up all the hospitals in the system. But it's important to know that this is very much a big hospital system or academic medical center thing. Not all hospitals have a specific pre-op clinic because it's very resource intensive. And oftentimes the surgeons and anesthesiologists need to do their own risk evaluation. So my interest is in applying AI to this domain to try and reduce the human capital required to do this task and to do this task hopefully better and to enable new healthcare workflows. So there are many existing risk prediction tools. Over the past few decades, we have started with organ-specific tools like the Revised Cardiac Risk Index. This focuses on using different patient factors to try to predict the risk of death or a heart attack or cardiac arrest within the next 30 days after surgery. And then anesthesiologists developed a more general grading scale called the ASA physical status classification. And this puts patients in general categories of risk that I like to call illness severity, because it ranges from perfectly healthy all the way to this patient is going to die in the next 24 hours if we don't operate on them. But probably what is the most comprehensive risk calculator out there is something that the American College of Surgeons have developed over time. It's the NSQIP Surgical Risk Calculator. And this is what they call a universal risk calculator that uses a single model to predict multiple outcomes. And I've listed a bunch of these outcomes here. But it's important to also recognize that there are many other risk calculators out there. And when there's this many options to do the same thing, it's likely because there's no single obvious choice. There's no crystal ball here for predicting the future. In order to understand what some of the pros and cons of the current clinical approaches, let's go through that commonly used and nationally validated NSQIP surgical risk tool. So this is kind of what it looks like. It's a website that you go to, you put in patient information. On the top, you'll see that I've put in that our patient needs a rotator cuff repair. So this is looking up the different procedure name or CPT code, and this gets factored into the predictive model. And then you have to extract out specific information. Some is a numerical value, some is a binary or categorical value that you then put into this risk calculator. And then it outputs this kind of this result where it's predicting different outcomes, the patient's risk relative to the population average, and it's also giving you a predicted length of stay at the bottom. Now, this risk calculator is built off of population average of a lot of patients, and so the developers did recognize that sometimes there are unaccounted for factors that a surgeon sees that the model's not seeing. And so if you look at the bottom right, there is a box where you can just like adjust the risk up and down based off of the surgeon's assessment. But this is essentially another input feature into the model that just makes adjustments to the output, but it is kind of a crude adjustment mechanism. So this model this application backing it is a logistic regression model. The input is 21 features, and initially it predicted 8 outcomes. It is powered with a model that has learned from a huge data set. So 400 hospitals in the US, 1.4 million patients, and many different surgical procedures. And if you look into the paper, you can look at what the AUROC performance is of this model, and you see that it's pretty good at predicting whether or not a patient's going to die or not, mortality. But then if you look down at specific outcomes, there are a lot of outcomes where the AUROC is only around 0.65 or 0.7, maybe 0.8. But that's just telling you that the model is not super accurate with some of these more detailed outcomes. In 2023, so last year, this model was updated to utilize XGBoost. And also they used a bigger data set of 5 million patients. So this is 3.5 times more data. And if you look at the performance, the performance of the XGBoost model is the box on the right. You'll see that the model performs much better. And they also trained a logistic regression classifier, which is shown in the red box on the left, on the same data for comparison. And so if you compare the two, you'll see that XGBoost does result in better predictive performance. Here's the AUPRC for the same data set and the same models. You'll see that it's, the values are much lower, but you can also see that XGBoost is doing a better job. Now, the question I had is like, how much of this is due to a model change and just the fact that they had 2.5 times more data? And so if you actually look at the logistic regression models from 2013 versus 2023, and you compare them, you can actually see much of the performance gain is actually because the data volume that the models trained on was vastly increased. Rather than AUROCs of 0.7, we're now getting consistent AUROCs of around 0.8, usually high 0.8s and close to 0.9. But as nice as this model is, there are some practical problems that come with trying to use this for risk prediction. So it requires manual data extraction by clinicians. Someone needs to go into the electronic health record for every single patient, figure out, which is the appropriate input for each of these. And if the data is missing, it's not clear what you do. You still got to put a value into this risk calculator. The other problem is typically we have patients who might have a special scenario or special features that we want included and factored in to our risk prediction. But we can't explicitly include these in this risk calculator. There's just that crude adjustment mechanism that I mentioned before. And unfortunately, this calculator, due to the terms of service and use, also cannot be used for population level risk stratification. So I'll talk about this a little bit later, but if you want to risk stratify a panel of patients or a whole population of patients, there's no automated way to use this risk calculator for that. So risk calculators, they're helpful in the clinical situation, but they're imperfect. How do physicians actually do risk estimation? And risk calculators can be a guide, but ultimately we are going to utilize our clinical judgment, which comes down to medical knowledge, reasoning, and our years of experience seeing patients and understanding how different clinical phenotypes tend to behave when we do certain kinds of surgeries. So the thing I like to ask myself is, if we had better models, or if we can use the models in a different way than we can right now, what are some ways that we can change current clinical practice? So I'll present you two example use cases. One is I talked about preoperative evaluation clinic and how it's very resource intensive. Well, you can imagine that if you can apply this kind of risk stratification at a population level, say all the patients who are going to your hospital who need surgery, you could compute a patient's illness severity or look at the riskiness of the surgery, and then determine whether or not they even need an in-person appointment or not. So for high-risk patients or risky surgeries, we may want to order further labs, further tests. We may want to medically optimize that patient to make sure they're in tip-top shape before we take them to surgery. We may even need to have a further discussion with the patient because maybe this patient is unlikely to do well if we took them to the operating room. And we should really talk to the patient about alternatives to surgery. That's appropriate for an in-person encounter with a patient. Now, other patients who are not so sick, but maybe have some medical conditions, we don't necessarily need to do as detailed of an evaluation. We can perhaps just do a video or telephone visit with them that's more convenient for the patient. And then this would result in overall less healthcare costs. And finally, there are many patients out there who are perfectly healthy and the procedure or surgery that they need to undergo is really not risky at all. And so perhaps a preoperative evaluation visit is not really needed at all. But currently, there is not really a super great way to do this kind of triage and figure out how to route the correct patients to the pre-op clinic. In the operating room, you can imagine if we were able to risk stratify our patient population, we can change our resource allocation in the operating room. So if we identify sicker patients, we can allocate more clinical resources. We can reschedule their surgery so that it happens first case in the morning rather than 5 p.m. In the evening, and then most of the hospital is going home. If something happens, you don't have as many hands on deck in order to help out. And then we can also consider adjusting staffing so that maybe we have clinicians who are de facto experts at certain surgeries or diseases for those sick patients. You can also think about the postoperative resource allocation in a hospital. If we are able to better estimate if a patient's really ill and they're likely going to be heavily impacted by a surgery or procedure, maybe we need to reserve a hospital bed or ICU bed for this patient after surgery. Right now, it's just kind of up to a clinician guesstimating, but it would be nice to have a tool that would allow us to do this. So high-level conclusions from this section I want you to take away is that risk calculators exist, they're useful, but there are a lot of issues and limitations with them. So they don't account for many variables. The outputs really reflect population averages, and they're not tailored to the specific individual patients. If a patient's situation is atypical, then it's not really clear to me if a risk calculator if the risk that is predicted is still applicable to that patient. Furthermore, the risk calculators don't provide any explanation or rationale for its prediction. And unfortunately, some of the best risk calculators, like the NISQIP tool, is a closed source model that's deployed on a website, and it requires that manual human input. So it really limits the utility for population level risk stratification use and stratification for the pre-op clinic and operating room and use cases like that. So for the next portion, I'm going to move on to some of the research that I've done. The first of which is we took the pre-trained bioclinical BERT model, and we asked the question of whether or not we can use it for illness severity stratification. So this is now seeing if we can go beyond the traditional risk calculator. Can we use a language model to quote unquote read a clinical note in the electronic health record and make a risk prediction? And why is this different than these other risk prediction models? So clinical notes in the electronic health record contain information that doesn't really exist anywhere else. It contains a physician's assessment and impression of that patient, how they're thinking about the patient, and it also contains the clinician's plan of action given the current state. And as a human, when I practice, I go into the electronic health record. One of the first things I do is I look at the notes. I see what's going on with a patient, and then that frames everything after that. I can then go look at the structured data elements like vitals, labs, medical conditions. But it's really helpful to have that framing from the physician's description, and that's all in the notes. So if you think about it, the risk prediction models, which I talked about before, they essentially ignore these clinical notes because they have no way of accounting for them. But language models can use this information, which makes them interesting. So we took the bioclinical BERT model. This is the BERT model that's been trained on biomedical and clinical texts, essentially PubMed and the Mimic3 ICU database. And then we took this model and we fine-tuned it on clinical notes that came from UW Medicine. And we asked it to predict the ASA physical status classification that I mentioned earlier. And then we also compared it against several baselines. So we compared it with other NLP models like FastText. We also created a classifier that just used the patient's age and medication list in order to try and predict their illness severity. So data curation was a big step in this project. So traditional risk prediction models are built using these giant multi-center clinical databases that have been curated over time, and essentially a human has curated these data variables. Generally, these databases don't contain clinical notes. Those are generally just in hospital-specific EHR data sets. And so I set out to build our own data set using the UW Medicine EHR data. We extracted about 61,000 surgery cases over 5 years. And essentially what we did is we took a specific note, which is called the anesthesia preoperative evaluation note. This is a summary of the patient's medical history, which surgery they're having, and the reason for surgery. And we put this as an input into the model, and we asked it to predict the ASA physical status classification. So this is just kind of an overview of our data set creation, and then how we split the data into the final train, validation, and test set. This data originated from UW Montlake as well as Harborview Medical Center. And so I've been talking about this outcome that we're predicting here called the ASA physical status classification. This is essentially a categorical scale. There's actually, it actually goes from 1 to 6, but 1 to 5 is really the illness severity assessment. And you can see that ASA 1 is a healthy patient. There's essentially nothing known wrong with them. And then as they get sicker, they move down toward ASA 5, where ASA 5, these patients essentially need the surgery or else they're not going to survive and it's projected that they'll probably die within 24 hours if they don't get the surgery. So that is like an extremely sick patient. I didn't mention that there's a 6th category called ASA 6. This is specifically for brain dead organ donor cases. So it's really different than these other 5 categories because in ASA 6, the patient has already been declared dead. We are just, the procedure is solely for harvesting organs for organ donation. So the thing to know about this, this outcome scale is really they're fuzzy categories. There's no strict criteria. These definitions, they're just general descriptions of what should go in this category. But unlike many other clinical scales in medicine, a lot of clinical scales in medicine, they have very strict inclusion and exclusion definitions for each of the diagnostic categories. But there really isn't one for the ASA score. We're really relying on the anesthesiologist to make a holistic clinical assessment of how ill this patient is across all their organ systems and their problems, and put them into one of these buckets. So we trained all those different models, and we found that bioclinical BERT was the best. Here, what I'm showing you is an AUROC curve for each of the output classes. For this particular study, because we had so few patients who are ASA 4 and 5, and they're, the meaning of ASA 4 and 5 is that they're all pretty sick. We just combined those classes together. What we found is that the predictive performance we have from just using clinical notes to assign a illness severity score, the ASA class, it's worse than the NSQIP surgical risk calculator, but we also had 20 to 80 times less data. And as you saw earlier, going from 2013 to 2023, when they scaled up their data size, their prediction performance got way better. So this was kind of interesting because it suggested that we could use language models to do this kind of risk stratification. We also looked at whether or not, so we did 2 things. One is we first looked at the age and meds classifier and we compared that against the language model. And you can see that the language model is doing a much better job at categorizing patients. On the y-axis, that's the ASA score that the anesthesiologist assigned when they were taking the patient to surgery. And on the x-axis, you'll see that this is what our models are predicting. And so the optimal model will only predict along the diagonal. So you'll see that in bioclinical BERT, if the model is making a mistake, it's making a misclassification to an adjacent ASA class. And this suggests to me that the model has learned something about the text descriptions of the patient and is not making these huge errors. And the models are appropriately associating the text features with illness severity. It's very rare for the bioclinical BERT model to make predictions that fall in the red boxes, which I call catastrophic errors, because these are completely wrong predictions where the anesthesiologist said, oh, this patient is ASA 4 or 5, and this patient is really sick, but the model said, hey, this person is perfectly healthy, it's ASA class 1, or vice versa. The other thing I mentioned before is that you have to keep in mind that there's an imperfect ground truth. So the ASA score only has moderate inter-rater reliability among anesthesiologists. If you take any two human anesthesiologists and you give them this data set, you're going to get a different confusion matrix here. Because there's no strict diagnostic rules for what belongs in ASA class 2 versus ASA class 3. So it's actually, because we have imperfect ground truth, it's also essentially impossible for models to perform perfectly. We just want models to perform better. So the next thing we did is we're curious about those red boxes, the catastrophic errors. Like, is the model really making such a bad judgment call in these situations? Or is there a problem with the original label in the data set? Now, keep in mind that because we extracted our data set from the electronic health record, the labels could be noisy. It's possible for a human to input the wrong value into the electronic health record, and then that becomes the wrong value in our data set. But we wouldn't know ahead of time. So we did a study where we took these catastrophic error cases, and we had, on these plots, you'll see that the red bar represents what the model's predicting, and then the green bar represents what the original anesthesiologist wrote down in the electronic health record. And we took 3 new anesthesiologists, and we said, assign a new ASA class to this without knowing what the model is predicting and without knowing what the original anesthesiologist put down. The results of these 3 anesthesiologists are plotted for every single case as dots. And so you can see that while there is variability, overall, the new anesthesiologists are agreeing with the model's prediction. And when we look at the examples much more closely, when we read the text that's going into the models, we can see that there are actually a lot of these cases which we label as catastrophic errors, but really the original label in the data set is wrong. It's essentially saying that despite the fact that we have a noisy ground truth here, our bioclinical BERT model fine-tune is still able to learn beyond that and still able to make reasonable predictions. We also did some analysis using feature attribution with SHAP to explore the model interpretability. For those who are not familiar, SHAP assigns a value to every input feature, and in this case, that would be every word or token in the text. And the value of the SHAP value is shown as a heat map. So values that are red indicate that the model believes this is evidence supporting a particular ASA class. Whereas if it's blue, that means it's evidence against. And when you add up all the evidence, you essentially get the probability that the model will predict the ASA class. So if you look at the force plot above the text, you'll see the addition of all those, all the evidence, and you will get the model's probability prediction. And in this case, the model thinks that the patient is ASA class 1, which is actually true. This patient, despite a lot of scary words being mentioned in this text, overall is pretty stable and is not had an injury, but nothing terrible is happening. And so, and the patient's previously healthy, doesn't have any major medical conditions. So I would classify them as ASA class 1. And so the cool thing about this is that it's actually very easy for a clinician to see what the model is focusing on to make its predictions. And when we did a more in-depth analysis, we found that the model was appropriately picking up on relevant keywords that correlates with the patient's illness severity. So conclusions from this study is that we found that language models can perform risk stratification using only a text description of the patient and recent clinical events. And the best performing model out of all the ones that we tried was a fine-tuned bioclinical BERT model, which is a transformer-based model. And we concluded that using text as input to a model may be a reasonable alternative to traditional risk prediction models that only use tabular features. So for the next part, I'm going to move on to some of the more recent work that we've done, which is using large language models to do this sort of perioperative risk prediction and prognostication. So most people are probably aware, if they've been keeping up with the news, that large language models can do some pretty incredible things. And a lot of LLMs have been benchmarked on a data set called MedQA, which is essentially a data set containing USMLE questions. And USMLE essentially is a medical licensing exam. It's a exam that every medical student needs to take in order to be able to go to residency and stay in residency. However, it's not necessarily perfectly reflective of real-world medicine and doesn't reflect necessarily any particular specialty or the specialty boards. But it's still a good indicator of the LLM's knowledge capacity and capability. The best LLMs these days can now achieve quote unquote expert human level performance. So that's pretty exciting. But as I mentioned before, real world medicine, it's not a multiple choice test. If you look at the data in the EHR and what happens in real world medicine, there is a lot of uncertainty, there is noise, we have information that's missing, we have conflicting information, we have outdated information. In contrast, in MedQA, you're given it's a multiple choice question, first of all. So like you clearly define what the possible outcome space is. And then usually the question stem will give enough information that you can make the link to the correct outcome. But this is not the case with real world medicine. So we asked the question, can LLMs perform perioperative risk prediction in the real world? And so if we go back to the question, is it safe to go to surgery? The challenge is there's no single definition of safe. In our previous study, we used ASA physical status classification because it was an outcome that was relatively easy to extract out of the electronic health record. There's essentially an ASA score assigned by the anesthesiologist for every single case. But if we want to do more comprehensive assessments, there are potentially many indicators of what a patient having high perioperative risk looks like. And so we have potentially a lot of surrogate outcomes, but the other thing is we don't necessarily have this giant national database that has carefully curated data. We have, however, the data at the UW Medicine EHR, and so we thought of which variables we could easily extract ground truth out of the EHR, and we came up with these 8 different outcome variables. In essence, these outcome variables all vary in terms of what they represent, but if you go from top to bottom, the bottom outcome variables are indicators of greater risk. And the other thing to be aware of is that some of the outcomes we're predicting are binary or categorical, others are integer values that we're asking the LLM to predict. And so this is actually a variety of different tasks that we're going to ask the LLM to do. So our experiment setup, we use GPT-4 Turbo, and then what we're going to do is we're going to tell the LLM what the specific prediction task is. We're going to then give the specific surgery information. This is actually what we did is we took the surgery case booking information, so what the surgeon put down and gave to the operating room. We took that information, pulled it into the prompt, and then we took the last 10 clinical notes in the patient's electronic health record prior to surgery, and we pulled that into the prompt as well. Now, clinical notes can be quite long, and so in order to conduct some prompting studies, what we actually ended up doing is we took the 10 clinical notes and we asked GPT-4 Turbo to summarize that into a single paragraph. And this allowed us to do some more sophisticated prompting techniques. And then finally, we asked GPT-4 Turbo to give us the answer to that prediction task and also a text explanation. So creating the data set from the electronic health record was quite a challenge. This is just to indicate that it's fairly complex, but at a high level, essentially what we did is we took 2 years worth of UW Medicine electronic health record data from DOG, or the Data Analytics Galaxy Warehouse, and we represented all surgical and procedure specialties that required anesthesia care. And then we created data sets where we had to downsample the data sets to create task-specific data sets with a target of roughly 100 cases per task. And we ended up doing this because if anyone has tried to run really long prompts with the LLM services like GPT-4 Turbo, it gets quite expensive. And we ended up spending thousands of dollars doing inference for this study. And we only did about 1,000 cases per task. So what does it look like? So on the left here, what I'm showing you is the prompt that we construct. The highlighted portions of this prompt is actually the patient's information that is being injected into the prompt. And so on the green line, this is the specification of the specific task that we want the LLM to perform. In this case, what is the ASA's physical status classification? The yellow shows the surgical case booking information. So this is like the surgeon booking, I'm going to do an AFib ablation procedure. And the reason is because the patient has a diagnosis of paroxysmal AFib. And then there's some other information like what service the provider is from. I mentioned that we took the last 10 notes, we summarized them, and then we put them as part of the context. And then we asked the LLM to generate an output. And then we did also experiment with chain of thought reasoning, which is a special LLM prompting technique and so in this particular illustration, we're using chain of thought reasoning, and this is how we induce the chain of thought reasoning. The green box on the right is the output of the LLM. And so in this particular case, because we're doing chain of thought reasoning, we asked the LLM to give its step-by-step explanation of what it thinks the ASA physical status classification should be, and then provide the answer after it has the ability to attend to that explanation and rationale. So if you look at the explanation, one very interesting thing is that we took a general domain off-the-shelf language model. GPT-4 Turbo is not a healthcare specific language model. And yet it knows the definition of the ASA physical status classification. It knows the different categories. It then summarizes the patient and is able to assess how that patient's representation fits into one of the ASA class categories, and then it gives the final answer. So that's kind of cool because this kind of parallels what I would actually do as a clinician, and is much more human-like than what a traditional risk calculator is doing. So I mentioned we tried different prompting strategies. We also did few-shot prompting. Few shot prompting, we took whole cases of task, procedure case booking, last 10 clinical notes summarized, and the final label that came from the electronic health record. So we gave each of those as in-context demonstration. So for a 50 shot, we gave 50 of those in the prompt, and then finally asked it to predict for the specific query case. For chain of thought prompting, for when we didn't do chain of thought prompting, what we did is we asked the model to make a prediction first, and then we asked it to give an explanation. When we asked for chain of thought prompting, we forced the model to explain step by step its rationale first, and then ask it to predict the final answer where it's able to attend to its rationale. So how does the model do? So GPT-4 Turbo is actually able to do some of these tasks pretty well. These are just some of the categorical and binary outcomes. As you can see, as we move from left to right, we're basically increasing the few shot prompting. The first two items on the x-axis is essentially the difference between doing zero shot prompting with the last 10 clinical notes versus zero shot prompting and the summary representation. But in order to do few shot prompting, because the prompt gets so long, we had to use summaries. And so for all the few shot prompting experiments, those use summaries of the patient's notes. And the orange line shows when we add chain of thought prompting. And so you can see here, and we're measuring the outcome here as a F1 score, which is very commonly used for classification tasks. So you can see here that as we use few shot prompting, the performance tends to get better. And as we do chain of thought, the performance gets even better. So these are synergistic. One interesting thing is that at first glance, it looks like the ICU admission prediction didn't really benefit from chain of thought or few shot. But if you look at the F1 score achieved, it's actually quite high. I've shown the baseline F1 score in the purple dashed line. This is like what a random classifier would achieve. So you can see that the LLM has quite good discriminative ability of whether or not a patient is going to go to the ICU after the operating room, which is quite interesting and potentially quite useful in the clinical setting. These are two other categorical outcomes. So for unplanned admission, we actually found that it was quite difficult for language models to predict this, and doing few shot and chain of thought prompting didn't really help it very much. And we suspect this is because for unplanned admission, it is more due to intraoperative factors than the patient's preoperative state. So what unplanned admission means is that we took, when a patient books the surgery, the surgeon also puts down whether or not they expect the patient is going to be discharged on the same day and not need a hospital stay, or whether or not the patient needs to be admitted to the hospital. So that's the surgeon's expectation. If what actually happened in the electronic health record was different than the surgeon's expectation, we call that an unplanned admission. So our thought is that, this unplanned admission is more likely like maybe something, something unfortunate happened in the operating room itself. Well, that's not really something that you can get from a patient's preoperative state and the state of their electronic health record. And so that's probably why the LLM is not able to predict this task very well. However, they are able to predict hospital mortality, which is whether or not a patient is going to die after surgery and admitted to the hospital. So, and the F1 score is quite high for this test. So this is also pretty useful clinically. We just looked at the confusion matrix to compare against our previous study. And in this case, we see that GPT-4 Turbo, it rarely makes those catastrophic errors. And actually, when you start doing few shot prompting and when you start adding chain of thought, it essentially never makes a catastrophic error. All the mispredictions compared to the label for ASA class is really just they're predicting an adjacent ASA class, and that's why we're counting it as wrong. Now, when we look at the numerical outcomes, so for these, we predicted PACU phase 1 duration, which is how many minutes a patient is going to stay in the recovery area after surgery, hospital duration if a patient was admitted, and also ICU duration. Those are measured in days. So these are numerical outcomes that we ask the model to predict, and we measure their performance using mean absolute error. So in this case, you actually want a low error, and so a lower number is better. And you can see that if you compare the LLM performance against a random classifier, they do terribly. LLMs don't seem to be able to do these numerical outcome prediction tasks. And why is that the case? Well, we dug into the data a little bit further. So each of these plots is showing one of the prompting strategies. Each dot is one of the cases. And on the y-axis, we're showing so this is for hospital duration. So for y-axis, we're showing this is how many days the model thinks the patient's going to stay in the hospital. On the x-axis is what actually happened. And if you look at the zero-shot prompt strategy, you'll see that there's this kind of ceiling effect. The model almost never predicts that a patient is going to be in the hospital more than 14 or 20 days. And we think that's because models like GPT-4 Turbo, which trained on massive amounts of general domain website, publicly available data, they probably have learned from hospital websites that, oh, for this kind of surgery, typically you should expect that you're going to stay in the hospital for this many days. That's probably where it's getting some of its knowledge, and that's biasing the model to never predict more than a certain number of days. However, when we start adding few-shot prompting, you'll see that we are adding in-context examples from our UW dataset that helps the model adapt to real-world data in our dataset, and we overcome the ceiling effect. But unfortunately, the distribution of the predictions and what actually happens is not very good still, and so it's not good enough performance for real-world clinical use. So why are LLMs bad at numerical predictions? Transformer models have been successfully applied to numerical prediction tasks like time series prediction, and oftentimes there are time series prediction models built on transformers that achieve state-of-the-art results. But specifically for LLMs, if you think about it, there's potentially two reasons. One is we're using general domain LLM. It may not have adequate domain-specific knowledge, and these LLMs are instruction tuned, and so the instruction tuning may not be domain-specific enough for healthcare, and maybe that's why these models are just not able to make good predictions. Another reason is specifically for language models, we take in a text input and we tokenize them, and then we feed that into the model's latent space. So the tokenized representation may just be very suboptimal for numerical representation. If you look at some of the work that's being done out there with LLMs, especially with multimodal data, there's been an increasing number of research studies that have used LLMs that take different data modalities like waveforms, images, numbers on a continuous scale, like age, BMI, lab values, and they have a separate encoder that directly maps these data modalities into the language model's latent space, so essentially bypassing the tokenization step, which might be an unnecessary bottleneck for some of these data modalities. And so, potentially this sort of paradigm could overcome some of the problems we see with numerical prediction, but more study is needed in this direction. So in conclusion, current general domain LLMs like GPT-4 Turbo, they can be used for perioperative risk prediction, but mainly for binary and categorical outcomes. And we really just did a small scale research study, although with real EHR data, it remains to be seen whether or not this kind of performance is good enough for real world use and needs to be validated in a prospective clinical study. We also see that LLMs, at least the current ones we have right now, just have poor performance on numerical prediction tasks. But one of the great advantages of LLMs is that they can generate text. And so they're able to generate good explanation and reasoning for their predictions, which as a clinician, I can read that and I can understand what the LLM is focusing on in order to make its prediction. And because it's grounded in the individual's EHR data, it is essentially personalized it's a personalized risk prediction. We're not exactly dealing with population average risk predictions like traditional risk prediction models in the same way. And my hope is that if LLM-based prediction tools improve, they can eventually become complementary tools to the traditional risk clinical calculators that we are using. And that would be very interesting to how we would be able to do precision medicine in the modern day. So thank you for listening to this talk. My work is supported by a lot of different researchers and faculty members from both Stanford and University of Washington. And I really couldn't have done this without some of my mentors here, Nima, who's my current mentor. But when I was at UW, Vikas O'Reilly-Shaw, who's one of the pediatric anesthesiologists, Drew Walters, and also from biomedical informatics, Maliha Yediskin, who served as my NLP expert and advisor. So thank you very much. And I think we can open it up for questions.